Oh, hi there. Let's talk about vomiting. So, a little while ago, a 45-year-old female came to the ER and was complaining of nausea, vomiting, and some stomach pain for about the past 2 weeks. She tried to detox herself because she had a bout with alcoholism and she realized it was a kind of a problem. Tried to kick herself down to one beer instead of her usual six. Later that afternoon, she started feeling a bit shaky. She had increased nausea and stomach pain and diarrhea, and so she came to the ER. Her family was there and brought her, and she was presented a little bit delirious. Part of her symptoms she was having as well was some back pain and stomach pain. Past medical history includes alcohol abuse, pancreatitis, hypertension, liver problems, depression, anxiety. Not really any surgical history, denies any allergies, no medications prior to her visit to the hospital. She has a couple kids and no history of tobacco abuse, though she does have a little bit of history of alcohol abuse. She drinks hard liquor and she smokes marijuana like everybody else, all my patients in Washington State. No family history, it's significant, and couldn't really talk to her about anything else she was feeling because of her state. Vital signs showed an increased heart rate and a little bit of increased respiratory rate that you can see here. Other than that, she had a little bit of injected sclera. She had a little bit of tachycardia. Her lungs sounded clear, but she did have some CVA tenderness in her abdominal exam. Neurologically, it was kind of difficult to assess due to her state. Her labs showed that she had an increased increased white blood cell count that you don't typically see. She also had an elevated AST, as you expect someone that's been drinking recently. She had a little bit of a decreased potassium, and her UA had a lot of white blood cells in it. So things you think of in this patient, obvious one, alcohol withdrawal, electrolyte abnormalities, pyelonephritis, and sepsis. So sepsis is what we're going to talk about today, and septic shock. So there's this really cool algorithm for dealing with sepsis that I'm probably not going to go over right now. But I do want to talk about what's going on in the body, kind of breaking down the little processes that happen every day to people that go into this problem. Now, you might recognize this, those people who are frequenters of YouTube. There's a channel called MedCram that goes over shock, and I kind of stole this little format from them, this diagram at least, of how they do it, and add a little more complicated spins to it. You can see that the heartbeat is spitting out blood, RBCs, to your body. And it's really simple. You can divide things up into important organs and unimportant organs. Not that things aren't really that important, but some things are less important, like, for instance, your skin is not a high priority as your brain. And so that's kind of the approach I want to take when we're looking at sepsis. So let's define some really basic things and see what happens when we zoom in on one part of the body. Right here. So when you look at these things, they kind of look like little flying tums going through your blood vessels. They're supposed to be red blood cells. And you see this little bacteria come down, and it can come to your body in different ways. This patient, she had some pyelonephritis. It was most likely the cause of hers. The bacteria will get into your body. Sometimes it stays intravascular and interstitial, and also in the interstitial areas as well. Your immune system detects it and takes care of it and has a reaction of its own. It releases cytokines into the body, things like tumor necrosis alpha, interleukin 1, and it causes this vasodilation. You can see how it affects the body in general. You get a general redistribution of your vasculature. So more blood flow will go to your unimportant organs and then typically goes to your important organs, or rather just less will go to your important organs than they usually expect. And some of those unimportant organs, like skin, you get an increased blood flow because it causes temperature changes. things like a fever. The skin just feels warm to the touch. This is much different than what you see in patients that have cardiogenic shock or have hypovolemic shock. They typically have cool extremities and cool skin. You see a decreased systemic vascular resistance, a decreased blood pressure, and the heart will compensate by tachycardia. And it won't be happy about it. In general, this little red cylinder to the left kind of represents your body's vasculature and how everything's distributed. And you can see it's really poorly distributed throughout the body. And it's not happy. You'll have an increased respiratory rate. Those are lungs right there. Part of your important organs. You have an increased respiratory rate to kind of compensate for your increased oxygen demand that your body's having. You see your body's getting less red blood cells than it usually does. And as such, you need to compensate by your body tries to saturate more by breathing more. And of course, you have your foreign invader there. And you have an increased white blood cell count typically. Or at least some changes. Now, if we attach some numbers to what's going on, you can see we have something for a criteria called SIRS, or Systemic Inflammatory Response Syndrome. And you've heard of this. So you can have any two of these presenting criteria. So one would be increased heart rate greater than 90. Another would be temperature changes greater than 100.4 or less than 96.3. You can have an increased white blood cell count of 12 or less than 4. And increased bands greater than 10%. You can have increased respiratory rate greater than 20 and a PaCO2 of less than 32 because your body's trying to adapt. And so there's some numbers that you can kind of see. If you look at our patient that we have, you can see from her physical exam on her vitals, we have an increased heart rate. We have an increased respiratory rate, meeting the criteria of that alone. And to kind of top it all off, we also have an increased white blood cell count of 18.5. So she definitely meets the criteria of SIRS. Now, let's take this one step further. And if we add one more component to this, a suspected infection, then we get sepsis. So sepsis is simply just SIRS plus a suspected infection is sepsis. And our patient, clinically, you can decide that. You can look at our patient, looked at her UA. Looks like she has a urinary tract infection at least. She has some CVA tenderness, suggestive of a type of infection. Often you'll look at chest x-rays and you'll see some type of an ammonia infection going on, or perhaps a wound, what can be there as well. Some conditions will mimic sepsis. You don't always want to make this judgment just basically off of lab values alone. You want to also consider other things could be going on. Heart attack can cause some of these presentations. Pancreatitis. I like this one. Overzealous diuretics can cause it. So different things can present in this way. Now, if we take this another step further, and let's say we have end organ damage, that's called severe sepsis. Things we think about with end organ damage: acute lung injury, acute kidney injury, encephalopathy, coagulopathy. This patient, she had a little bit of delirium from her alcohol withdrawal. It was difficult to kind of distinguish that from what was that versus encephalopathy from sepsis we were having a hard time with. Now, take this another step further. You have sepsis plus hypotension despite adequate fluid resuscitation. You'll have septic shock. By hypotension, we mean a systolic blood pressure is less than 90. And by adequate fluids, we mean at least an infusion of 30 milliliters per kilogram of crystalloids. Typically, we use normal saline. You can use lactated ringers. You can use albumin in some cases. But typically, normal saline is what you want to use for fluid resuscitation. Now, sepsis is kind of a really big deal, and you can have a lot of problems with it. Most people, not most, 30 to 50%, you won't survive a encounter with severe sepsis. Septic shock, typically the number is worse, 50 to 60%. Now, Emmanuel Rivers did a landmark publication about early goal-directed therapy in a New England Journal of Medicine back in 2001. He was a critical care doc, board certified in that and emergency medicine. He discovered following certain protocols and directing at certain targets was a better way of approaching patients with sepsis. They had much better outcomes. And so this changed a lot of things.